I'm excited to present this session with my colleagues, Dr. Samar Khalil and Dr. Wasim Bakour. My two other colleagues couldn't make it here, and unfortunately we couldn't do a remote setup, so Dr. Bakour and myself pitched in to do two other sessions. So in this hour session, we will, longer than hour, we will cover eyelid rejuvenation. I think it's very important in our field. We will discuss the aesthetics of skin cancer treatments. That'll be myself. Dr. Samar will discuss important information on microneedling and radiofrequency. And Dr. Bakour will discuss his experience with laser scar removal in continuation of the session that was discussed before, and new targeted treatment for acne using lasers, and that's a very exciting field. So let me start. That's the pointer, okay. So I love treating the eyelid, and I think it's a challenging area that is often, difficult, often overlooked by colleagues. And in order to improve this area, of course, we need to know the anatomy. The eyelid area has its 4 layers: the skin with its epithelium, the dermis, and a very loose areolar layer that replaces the normal subcutaneous fat. There's a muscular layer with the orbicularis oculi, the levator palpebrae, and the superior and inferior palpebral muscles. Underlying fibrous layer, which is the tarsal plate and the conjunctiva. Of course, our job is that first layer. Sometimes we get into the second one when we use toxins. The eyelid skin per se is the thinnest skin of the body, and that's where aging starts showing. It's 0.3 to 0.6 millimeters on the upper eyelid, 0.5 to 1 millimeter, a bit thicker on the lower eyelid. There are tiny hairs, sebaceous glands, few sweat glands. As I said, it's the most delicate area where aging shows because of the constant movement, because of the exposure to sun, because of the underlying anatomy. Of course, for the longest time, blepharoplasty was the only solution, and sometimes as dermatologic surgeons, we have to do this, or we refer to our plastic surgeons. And the upper blepharoplasty is often, an easy solution for patients with low risk. On the other hand, the lower eyelid is very delicate. It's a free margin, and surgery can often lead to ectropion, changes in the appearance of the eye, and it's usually avoided, and that's where we like to use our interventions. It's very important to look at the eyebrow before you address the eyelid, because a low eyebrow will always make the eyelid, especially the upper eyelid, much worse. So whenever we can lift the eyebrow, we will improve the upper eyelid. And there are techniques like radiofrequency, ultrasound, threads, or Botox that we will not discuss here. Sometimes we have to fix the eyebrow, and it's important to improve symmetry, like in this patient who was very sad because of the asymmetry that she has. And that's a really cool technique where we do a direct skin excision over the eyebrow. The scar is hidden in the eyebrow. You can see we can achieve a nice symmetry. This is a patient that I operated on in August of last year, and that's her about November of this year. A nice, cool thing that you can do quickly. So when it comes to the eyelid per se, what do we have to offer? We have, of course, the injectables, we have lasers, energy-based devices, and we'll get over that. But before we get there, again, another indirect way to improve eyelids is filling the temple, because when you have a sunken temple, sorry, I'm not, okay. The skin tends to go in medially, and it worsens the damage of the eyelid. So merely lifting the temple with some volume will lift the eyelid laterally and improve that area. So what can we do exactly as dermatologists? We can treat the wrinkles, we can treat the laxity, we can treat the hyperpigmentation, the tear trough, and the varicosities. I'm not going to discuss Botox very much. This has been life-changing in our field, of course. Lasers are very interesting to restore the quality of the skin, and we've always used ablative resurfacing lasers. They resurface the skin, improve the laxity, wrinkles, pigmentations, and it's always helpful to do toxins before so that the matrix is flat and steady as the skin is healing in. And you can combine with other procedures to help improve the results. My favorite tool today is the erbium YAG, but I've used the CO2, the YSGG. Whether you remove the top layer of, do a full ablative resurfacing or do fractional resurfacing, or you do both, depends on what you are treating, on your tool, on the problem that you are trying to improve. And this is an example of using the erbium YAG laser. You can see how much improvement there is in terms of wrinkles and pigmentation, and see the improvement that it does to the face. The only intervention that was done here is just eyelid resurfacing, and you can see how much it gives clarity, glow to the face, beauty to the face. Pigmentation is a big issue, especially in this area. It's common, can extend to the cheekbone, gives this constant tired appearance, no matter how tight and young the face is. If patients have darker circles, they look tired. Of course, you have to differentiate between true hyperpigmentation and a simple tear trough, because the first one should be treated differently than the second. What we're talking about here is the idiopathic cutaneous hyperchromia of the orbital region, where that you can enhance with UV light, but I think most of us can tell pigmentation. Here's an example that I treated a long time ago while at Boston University with the Q-switch alexandrite. It's important to realize that these take time to heal, months and months for the pigmentation to be reduced. And then I started playing around with combination of CO2 and the Q-switch alexandrite, as in this patient. That's, a life-changing result here from one session. Currently, I use a combination of 3 techniques: the fractional laser, followed by the Q-switched, currently 532. Before that, it was the 755. And then I do a spot ablation. It's an aggressive treatment for dark circles, and as you can see, patients in the middle photo the next day. But on the 4th day, they're already much better. On the 5th day, they can apply their concealer and go back to normal. This is the kind of results that we see with this combination technique at 4 months, which is when the results really start showing. At 8 months, see again the effect on the full face, the clarity that it gives. We often combine with treating, the raccoon area. And here's a patient that I saw 6 years. I saw her lately, 6 years after a single session, and see the dramatic change from a single combination treatment with lasers. What else we can do for eyelids? Injecting PRP, currently exosomes, amino acids. A lot of products are being introduced for this area to help boost the regeneration of skin. The tear trough, my favorite thing is to not fill. If I can not fill, I'd rather do that. So whenever we can do laser to tighten the skin, I think it's better. Look at this result before and after a resurfacing laser result. She no longer needs a filler, and her skin is tighter and looks younger. Another technique that I strongly recommend, that is popular in my clinic now, is this non-ablative approach with laser, where I use the laser with a sub-ablative energy, so that we're not vaporizing tissue, we're only building up heat with this back and forth movement that you saw to build up heat into this area, usually delivering between 800 to 1,000 fractional shots of the erbium. And that heat stimulates initially contraction. Within a few weeks, you have collagen regeneration, minor sensitivity for 2 to 3 days, so it's non-ablative. People have no downtime, and see this kind of result. This is not unusual to be seen from a single session using this technique. Significant firming of the eyelids. Here's an example from my colleague, Dr. Bakour, after 4 sessions using the non-erbium YAG in the same technique with some stacking pulses on top. And this is really, it has been a game changer in our practice. Okay, now, when you have to use a filler, it's important to use HA. In my practice, some plastic surgeon colleagues might use nanofat. The lighter products are much more adapted for this area. HA is reversible, that's the advantage. Of course, always use ice, inject at the periosteum, and keep your hyaluronidase ready. This is an example that I did a few years back with fat, which I seldom used these days. What are the risks in this area? They were discussed in the prior discussion, so I'm not going to take a lot of time. But of course, the visible excess, the edema, the Tyndall effect, infection, biofilm, these are rare with good products. Vascular necrosis is always in the back of our mind, and and embolization and blindness, of course, are major issues. Why is that a concern? Because there's a backtrack of circulation to the ophthalmic artery from injecting filler in that area. And the risk is extremely low, but it happens. And if you're a busy physician who's injecting, if you do enough cases, you're really increasing your chances of maybe seeing one over a career. Therefore, having a good technique, knowing what you're doing, avoiding the injection to begin with, and doing it properly when you really have to is very important. And tiny amounts of hyaluronic acid have been enough to cause embolization. The treatment, when there is embolization into the central artery of the eye, first the symptom is pain, ptosis, diplopia, and blindness that follows. So pain is important, and ptosis are the first things that will happen. Injecting hyaluronidase in this area is very complex, and it is rarely effective. It can be injected immediately in the retrobulbar areas. There are some cases where it has been successful, or you can inject it intravascularly into the supraorbital artery, a very delicate thing that you want to have a nearby oculoplastic surgeon help you with. So to prevent, we use ice. I personally use ice. I use a needle. I'm not used to using cannulas. I always pull back, and occasionally I do get a backflow like you see here on the left. This is a patient, syringe that I was using. On the other hand, because there is no dogma in this field, using cannulas can cause embolization as well. And this is a colleague of mine, a plastic surgeon, who had a problem of embolization and vascular ischemia from using a cannula in the temple, which took some time, caused some TE in the scalp that resolved with time. Lastly, these tiny little vessels, we treat them routinely with the NDIAC laser, long pulse, low energy. We pull the skin out so that we are treating over the bone to avoid central, retinal damage. So I hope I covered what I think most of us should be able to do in our clinics, what at least we do as a group practice at Skin Experts, treating the wrinkles, treating laxity, hyperpigmentation, the tear trough, and the varicosities, and understanding the importance of treating the areas around the eyelids, as it is as important as the eyelid itself. Thank you very much.